female. In this case, she's a 22-year-old female presenting after an MVC, the right shoulder greater tuberosity fracture that was non-displaced. Patient was neurovascular intact and placed in a sling, made non-weight bearing.
How are you going to treat that?
So we'd probably treat this similarly to a proximal humerus fracture. Keep her in a sling, make her non-weight bearing for the time being. I gave specific instructions as well, since she's probably not going to be as painful as traditional.
When are you going to see her back?
I'll see her back in about a week or two.
Why?
I want to make sure the greater tuberosity fragment has not displaced or evolved. So I gave her special instructions, no active abduction or anything like that as well to prevent displacement.
No beach volleyball.
No beach volleyball. Thank you.
Good morning. First patient is a 4-year-old male, fell on the trampoline with a left both bone forearm fracture. Was closed reduced, placed into a sugar tongue splint. This is a 12-month-old male who started walking 2 weeks prior to presentation, and his sister promptly pulled him to the ground, sustaining his left femoral shaft fracture. He was closed reduced and placed into a spica cast. There's a 5-year-old male, well known to our service with type 3 OI, who sustained a fall and has his 4th acute on chronic right tibial shaft fracture. He was placed into a long leg cast, 5 valves. There's a 72-year-old female, status post fall, slipped on wet grass with the left LC1 pelvis fracture. She was made protected weight bearing, placed on DVT prophylaxis. There's a 58-year-old male who sustained a fall and had a right hip intertrochanteric fracture. Of note, he had a prior stroke with significant right sided weakness and was minimally ambulatory only to transfers. He underwent a right hip intramedullary nail. This is a 79-year-old female, status post fall with a right hip intertroch fracture. She was also taken for a right hip intramedullary nail. Next. Good morning. First patient's 59-year-old male, status post fall while he was attempting to punch somebody in this with a right distal radius fracture. He was closed, neuro intact. He was closed, he was placed into a sugar tongue splint. Next patient is a 50.
What do you think about your reduction?
I think it was the fracture includes an intra-articular split. This was the second attempt here. And it's, seems to be within acceptable alignment. He's just about at neutral volar tilt. He has decent radial height, which is acceptable, and his radial inclination seems to be good. His articular step off based off of these radiographs seems to be acceptable as well. So I think it's an okay reduction. I think we'll follow him up closely, make sure everything's maintained, but there's a good chance that it's not due to the level of comminution. Next is a 59-year-old male, status post crush. He was working at Home Depot and got a pallet that fell on his ankle. He has a left medial malfracture. There's also like this small non-displaced cortical fracture of his distal tibial shaft. He was initially. There is a third. Sorry, I don't have it included here. He was closed reduced and then placed into a short AO splint. CT scan was obtained. You could see this medial malfracture as well as the cortical fracture of the distal tibial shaft, which was stable. He underwent irrigation and debridement in right medial mal ORIF. Next is a 32-year-old guy, status post leaf blower. He was using a leaf blower, got his hand kind of caught into a fan. He has this index finger P3 fracture, as well as he had a big black kind of over the PIP joint, which was irrigated and debrided and washed out. There was no deep structures that appeared to be damaged. That was primarily closed. He was placed in bulky dressing with an aluminum foam splint over the DIP joint. This is a 59-year-old female with a history of ESRD, status post transplant a couple of years ago, status post fall and barbecue with a right distal radius fracture. She was closed reduced, placed in a sugar tonic splint. Next patient is a 64-year-old female, status post fall with a right proximal third humeral shaft fracture, neuro intact. They were closed reduced and placed into a coaps splint. Next is a 70-year-old female with a history of lung cancer with a biopsy proven met to this subtrochanteric region, who was status post fall out of the bathtub onto this left hip, who sustained this left pathologic subtrochanteric fracture. Underwent left femur IM nail.
Good morning. First patient is a 20-year-old female who is a pedestrian stroke and sustained this right medial malleolar fracture. She was closed reduced and placed into a splint and was recommended surgical management. However, she opted to follow up as an outpatient for further fixation. Next patient is a 65-year-old female who fell and sustained its left hip intertrochanteric fracture with some subtroch extension. She was medically optimized and taken for a left femur IM nail. Next patient is an 82-year-old female who was involved in a motor vehicle collision. She sustained its left open distal tibia plafon fracture, as well as a contralateral right intra-articular pilon fracture. She was initially treated with a left ankle irrigation and debridement and external fixation for bilateral ankles. This is the CT of the right pilon fracture that was done after X-fix for surgical planning. And 2 weeks later, she was taken to the operating room for bilateral ankle removal of hardware and open reduction internal fixation.
Anna, was the medial malleolus an isolated fracture?
That was the only fracture. She probably had like an ATFL sprain on the lateral side, but there's no fracture on that side.
Was it displaced? There was someone that presented one earlier that was very displaced. That looked like it was pretty much reduced.
The medial malleolus was minimally displaced, and I think I closed it down a little bit in my reduction.
So that won't heal on a splint. That's an unstable injury the way it is.
It could heal, but you'd have to follow it very closely. And just given her age, I think it would be easier to just fix it, just make sure you maintain her articular surface. I think my reduction is adequate, but I would have to watch it very closely to make sure it doesn't displace at all.
Is there any other surgical option for, either primary or staged fixation here?
For her ankle?
Yeah, for these pilons.
I'm sorry, I thought you were talking about the young lady.
Yeah, I would. Yeah. Thanks.
Dr. Kirschenbaum, were you asking about the pilons?
No, I was talking about that first case you presented. Yeah.
Oh, okay. And you're okay. Sorry, I'm just a little bit confused. So the older patient with the bilateral Elon fractures, you could consider doing. Yeah, I mean, you could consider for the right side, especially because it was significantly accommodated. You consider doing a fusion at that point. On the left side, I think that was the on the left side, we would have considered. Oh, sorry. On the left side, we had talked about doing an intramedullary nail, but she had a total knee prosthesis more proximally as well. So we just thought it would be better to just do open erection internal fixation distally, so we wouldn't have to. You'd have to just navigate around the prosthesis and didn't feel comfortable doing that.
I mean, these TTC nails don't go that high up, but yeah, that is an option. And it probably gets her moving a little bit quicker. I mean, it's a bad injury, so this lady's not going to go back to her normal function realistically at any point. So the goal is to minimize soft tissue complications and get them moving. I don't think it's wrong to plate it, but it's another option.
All right. First is the patient that sustained a right pinky tuck fracture. He was folding up his lawnmower when he got his pinky caught in the mechanism. Very impressive tuck fracture here. He also had a nail bed lac and a lac extended around the ulnar aspect of his digit to the volar pulp. So the nail was removed and the nail bed was repaired, as well as the lac. He was sent out on cat blood. This is a 26-year-old male that was in a motorcycle accident. He had this right first MTP dislocation. He was closed reduced and buddy taped and given a hard sole shoe. This is a 10-year-old male who had a fall. He was initially seen at an outside facility and given a sling and told to follow up with orthopedics. He somehow ended up here, even though he's from 3 hours away. He had this type 1 supracondylar humerus fracture. He was put in a posterior splint. This is a 60-year-old female who stubbed her left toe on a chair, has a left 5th digit P1 fracture. She was closed reduced and buddy taped and given a hard sole shoe.
Good morning. First patient to right-hand dominant, 12-year-old boy who's going down some slopes on a mountain, had a bicycle crash, and has his left supracondylar humerus fracture, was nerve intact. I was taken to the operating room for a fluid obstruction for James Penny. Next patient is an 85-year-old female, southwest fall with a right femoral neck fracture. She's medically optimized and taken to the operating room for a right hip hemiarthroplasty. Next patient is a 79-year-old female, southwest fall from the left femoral neck fracture. She's medically optimized, taken to the operating room for a left hip hemiarthroplasty. Next patient is a 23-year-old male, status post being pedestrian struck while on a bicycle, presented with a left open patella fracture with an anterior 2 centimeter wound. He was taken to the operating room for a patella ORIF and ID.
Good morning. First patient is a 14-year-old male who had a fall playing basketball, landed on his right hip. He presented with his right femoral neck fracture. He was taken. Timing of this was late afternoon. I think it was like 4 p.m. He was initially probably a little bit earlier, 2 p.m. He went initially presented to Rahway and then was transferred here. He went to the operating room around 7:30 that night. He went for right hip cannulated screw fixation. Next patient is 17. Yep. He's 14.
Without going across the spices?
I think we could have. I think, you know, the proximal femoral physis closed between 14 and 17, on average. So, I mean, I think it would have been difficult. We would have to have pretty short screws. The 16 mm screws we measured, they would have potentially been just short of the physis, but I don't think there's that much downside to sometimes we prematurely close the physis in someone with a skiffy, who's, 13 or so. So I think that's probably still going to be okay for him. But yeah, there's a little bit of a risk of that prematurely closing.
What's the risk of AVN?
So for him, it's transcervical. So the literature reports that to be about 30%, but that's with displacement, or known to be more displacement. I would say this is pretty much a non-displaced fracture pattern. So I think that the risk is going to be a little bit lower. But definitely something you have to watch closely and follow up.
Does he need more workup considering?
Yeah, he had a metabolic workup that was negative for any decreased bone disease. But yeah, that was negative. This is a 17-year-old female who presented about 3 to 4 months after an injury during lacrosse that she sustained on her right wrist. She never had x-rays done initially at that time, but she had persistent pain. She ended up having this right scaphoid, I guess I would really call this the delayed union. She was initially, when she was seen in the office, she was in a thumb spica brace, removable brace. She ended up undergoing a CAT scan to look a little bit more closely at the fracture pattern, showing a somewhat displaced scaphoid waist fracture with a little bit of what appears to be some osteolysis there, maybe concerning for possible AVN. The plan was to get her an MRI, which she did not obtain prior to going to the operating room, and she was we took her to the OR for a right scaphoid open reduction internal fixation with a vascularized pedicle bone graft. Unfortunately, the pedicle detached from the bone graft, so it really just was a normal bone graft. Yeah.
Why would you do a vascularized pedicle bone graft?
So there was concern that she potentially had some AVN, I think, preoperatively. So the plan was to basically, I think, do give her the best possible chance to have it heal appropriately. And the literature, from what I was reading, vascularized bone graft does have it's pretty comparable, but a little bit higher rate of healing in patients who have a scaphoid non-union with AVN. And so, I mean, I think I saw rates anywhere between 80 or 75 to 85%.
That literature is all over.
It is, it really is. So it's kind of hard for me to get a perfect idea down on it, but I think the idea was to do more for her than less. Ultimately, like I said, the vascular pedicle broke off. So really we just did a normal bone graft for her. But I think she
what
also—
pedicle were you trying to use?
I believe it was the 1-2 supraretinacular pedicle. So the one just off of your radial artery that we use.
What's the best way to determine if there's AVN?
We did that. So the best way to do is to drill into the scaphoid and observe for punctate bleeding. She did have punctate bleeding, so I wouldn't say necessarily this patient had AVN. And that's the best way. MRI is I'd say the second best way without.
Stop there. If you saw that at register, who said it?
Yeah.
The results of that are
just as good.
So if you have punctate bleeding, what's the chance of it healing without a vascularized bone graft? Without one?
Pretty high, 85% of just using bone graft.
Yeah. So Rusi looked at it, and some people have normal, some people have diminished, and some people have none. It's the one that has no punctate bleeding that goes on to non-union. The ones with normal punctate bleeding heal just like the normal population. And it's the ones that have decreased, which is hard to gauge, but somehow people who do enough of these can figure that out. But if you have punctate bleeding and you found that there was punctate bleeding, why would you then go ahead and do the extra dissection for the 1-2 supraretinacular vascularized bone graft?
No, then it wasn't a 1-2. It was the volar. It was the volar pedicle. So I guess I was mistaken.
Yeah, I was involved in this case. So just we checked for punctate bleeding. We acknowledged that it was there and that we probably didn't need a vascularized bone graft. We were using the volar artery, that kind of pedicle that comes right across the distal radius. And we kind of said, well, we can still try and see how it works. Because if it doesn't work, we're just going to use bone graft from the distal radius anyway. So it really was, I guess, maximum attending benefit at that point.
Yeah, we did not go dorsal.
So if you look at the preoperative films, it almost looks like the proximal pole is smaller. Definitely looks more sclerotic on the X-ray. So our concern was there preoperatively, but it did bleed intraoperatively. So hopefully it heals. I'm not really sure if it's easy to address this dorsally and go integrate with your screw because of that big cyst volarly. So I think it's important to to address that and pack it. So yeah, and taking a little chunk of cortical bone with that pedicle, which looks nothing like like it does in the textbook. It at least could give you something structural in terms of trying to resist any sort of late humpback deformity. But I think it looks decent. Hopefully it heals.
Rob, how long are you going to immobilize this patient, and how are you going to assess for healing?
So I would probably immobilize her in, I'd say almost 8 to 12 weeks, 3 months. I think eventually you're going to get repeat, obviously, X-rays, but I think ultimately to have a good assessment of healing, you probably are going to want to get a CAT scan of her wrist potentially, or you can't do an MRI because there's a screw there, you're going to have artifacts. So I would say CAT scan.
CAT scan is the gold standard.
Well, CAT scan is the gold standard to assessing for bony bridging. Yeah.
Not every patient needs that.
Okay.
If you've got an athlete that you're trying to get back, or you need to know whether it's balance, in many, I would argue that all of these cases, you do the best you can at this fait accompli. The CAT scan is not going to make it heal.
Yeah.
So, you can go radiographically and just sort of gauge a person based on their pain, what it looks like on an X-ray, and save the CAT scans for people that you need to put back into harm's way.
Yeah, I think you can just do X-rays for a while, and if it looks like it's getting good healing on X-ray, I think you could avoid the CAT scan. But there was future concern. I think CAT scans are gold standard to assess for bony
would
bridging.
you want to consider getting it at post-op? What would be something that might?
Post-op? I'm not sure. Obviously you get concerned for ADN, but I would say think with a screw in there, you're not going to be able to see anything. So
very well, they can do the Mars thing, but
it's still yeah.
So there's very little role for
yeah.
In my hand.
If that was it,
I do. Sorry, Dr. Hirschbaum.
That was a professional or a high-level athlete and needed to get back to sports as soon as possible. At what point would you let them go back in the healing process, and what tests would be would be the best to give you that information?
So I think you want to have 50% bridging bone, I believe. And so the best test for that would be a CAT scan to assess for bridging bone across the fracture site.
Okay, that's correct. That's based on laboratory studies. We don't have clinical data on that, but 50% healing with a screw in has the same bending strength as a regular scaphoid that's not broken. So that's the basis that you use.
Yeah, I was just about to say, in my contact athletes, I do routinely get a CAT scan before clearing them for sports.
The next patient is a 32-year-old male who rolled his ankle while playing with his niece. He presented with his left bimalleolar ankle fracture. He was initially placed into, it's a trimal. He was initially placed into a short AO splint, and he was taken the following day for a left ankle open reduction internal fixation with a syndesmotic screw. Next patient is an 87-year-old male who had a mechanical fall from standing, presented with his right displaced femoral neck fracture. He has a sort of AFib on Coumadin. He was medically optimized and his INR was reversed, and he was taken when medically optimized for a right hip hemiarthroplasty. Thank you.
Rob, did you stress that ankle before you put the syndesmotic screw in, or just put it in?
No, we did not. We just put it in.
If you trained in Jersey and Philly, we would call it a Ruzi. Everybody else calls it a Rousset.
Morning. First patient is a 75-year-old female, same trip and fall from standing with his right distal femur fracture. CAT scan was obtained. Showing that it does travel intra-articular. She's taken for a right distal femur ORF. Sorry, this is the most up-to-date CAT scan with the final films.
Did she have any pre-existing knee pain?
She did have a little pre-existing knee pain from pretty severe osteoarthritis. We discussed that she may have been a candidate for a DFR instead of doing the distal femur ORF.
Here's your particular part. Was it T-color or where was the?
It's a bit of a T-color. You can see the split. It's more or less non-displaced. Sorry. Right here.
Is she a big lady?
What was that, Dr. Person?
Is she a big lady?
Yeah, she is a big lady.
Does she have many medical comorbidities?
I believe she did have, she was not diabetic, but she was hypertension, hyperlipidemia. I believe she also had cardiac history as well.
So what was the pros and cons of ORF versus DFR?
So DFR would be possibly a larger surgery, more blood loss, although you could get her weight bearing on it more or less right away. The ORF, you're not necessarily prohibiting her from getting a DFR or total knee replacement later once she heals this. Just availability and planning for the OR. Would have had to have planned for the DFR right away to get the implants in-house.
The giant patient, I worry about the DFRs on giant patients.
Yeah.
I'd almost rather let them deal with this and at least get them set up. Maybe you can get them to lose a little weight, and then you can get her knees. There's a lot of people that have knees that look that bad and they do just fine. So
if she wasn't complaining of significant knee pain in terms of being immobile, she said she had some knee pain before fall. Next is a 25-year-old female who was ejected from a motor vehicle with a left open tibia, a left open iliac wing fracture, a left scapula fracture, left index finger metacarpal base fracture, and a left small finger metacarpal base fracture. She also had a C2 fracture treated by neurosurgery, as well as a ICA and vertebral artery injuries and cerebral infarcts. She's taking the OR for a left tibia IND, I'm now. Her iliac wing was irrigated and debrided, primarily closed. Her next metacarpal fracture is largely non-displaced. She's treated in a AP slab. And she has small displacement of her right small finger metacarpal base fracture. She was treated in only gutter splint. And then her left scapula fracture, she was treated in a sling.
How did you monitor her compartments?
For the tibial shaft, we actually, she was awake, despite the fact that she had these small cerebral infarcts. She was oriented ×3. We did frequent checks on her, just monitoring her neurovascular status. And I believe they took down the splint just to check it once.
Each check it more than once and somebody who's got it.
They checked it multiple times. They took the splint out once. Next is a 62-year-old female who fell down 5 steps with his right hip dislocation and anterior wall / AIS fracture. She was transferred dislocated from the outside hospital. Was closed reduced when she got here several hours later.
Probably was a really different reduction.
Yes,
You just have to rotate the foot a little bit and it just slumped in.
yeah, little traction and rotation. This is the CAT scan was obtained, showing that there was an intraarticular fragment as well. She was taken to the OR for a excision of the fragment as well as an AIS or F.
How did you approach that?
We did it through anterior approach. The fragment was fairly small, so we were only able to really fit 2 screws on it. We did initially, before we actually found that piece, we're considering doing an anti-glide plate or a spring plate.
If you think about it, you probably ought to do it. You may regret this one.
Yeah.
How big is this person?
She's actually not very big. She's fairly small.
And you're going to do protective weight bearing?
She's protective weight bearing.
And what? You just told her, just put a little bit of weight.
She's protective weight bearing with a walker.
Okay.
She's also.
Any other precautions for AIS avulsion?
Yeah, we're protecting her from the direct head of the rectus.
Say it again?
Yes, we worry about the insertion of the direct head of the rectus.
Okay, so maybe certain movements you'd want to avoid if you have 2 screws holding on to that piece.
Yeah.
What move? Shouldn't be just probably protected weight bearing. You're trying to have her avoid certain active motions that'll activate her rectus, right?
Yeah.
At least in the beginning, because the chances are that piece will escape. And how long was she? Did you document how long she was out dislocated before you got to her?
I believe it was 4 or 5 hours.
And what's the magic number?
By 6.
What happens after 6?
You have higher rate of AVN
and nerve injury. Although this looked like the anterior, I guess.
This was an anterior dislocation. Yeah, I think it was at least 4 or 5 hours.
Do you know where she was transferred from? Is it a place that does not have orthopedists?
JFK. This is the second one they transferred dislocated.
Yeah, you can request the reduction. Although you're a level 1 trauma center, the appropriate care, especially if you have an orthopedist, is a attempted closed reduction. It does delay care, but you're not.
I believe both her and the other one were both transferred as traumas. They did not contact orthopedic for the transfer.
Oh, interesting.
Yeah. And the other one they request is going to the OR today. They requested that we admit them immediately after they accepted the transfer. Next, the 46-year-old male fell 8 feet off of a ladder with a right open ankle fracture dislocation. He was provisionally closed reduced, taken to the OR about 3 hours later for an ankle ORF, the bridge plate. Yeah, there was a significant amount of comminution. There were several pieces of devascularized bone that we took out. We actually put. Yeah, and then this was considerably comminuted that the pieces were just free floating in there. They had no muscular or attachment at all, soft tissue attachment. We did put bone graft in.
Wait, so you took out the bone that was there and you put allograft in too?
Yeah, allograft in.
So you took out devitalized bone, patient's devitalized bone, and you put in devitalized not patient's bone into the void, away from the open wound?
Yes.
Does that make, which one do you think works better, allo or autograft?
Probably is autograft.
Listen,
yep.
like if you fell into a pile of dog shit, that's where it was. So yeah, you can always come back and bone graft it later. But
Yeah.
you had the balls to put bone graft in there in the first place. I'm not sure that it was on bone out.
There was really only one little piece that we took out, and we were surprised how much it appeared to be gapped or missing on the fracture.
Post-op though, so I didn't see a whole lot of bone there. There was much bone graft to put in there.
But 5 cc's of chips.
Now, the other question, what plate is that?
This was just the 1/3 tubular.
Looks like non-locking.
Non-locking.
So if your plan is, so you're bridging a bone loss fibula, do you think that's going to hold very well?
Yeah, my preference would have been to use a little stouter plate. Maybe they're just a fibula locking plates just to give yourself extra.
Maybe a couple of screws across the syllus.
Yeah.
Why not use it? Was there a concern for something?
That was the preference of the attending to use this plate.
Was there a plan to come back in the future?
No.
Is there a longer non-weight bearing period?
Yeah, I think we're gonna probably have to keep him non-weight bearing for probably closer to
2 months.
Yeah, I was gonna say 10 weeks at least.
That's kind of what is extra.
Yeah, that's it. Thank you.
Just his eyes.
No, there's just slits.
Yeah.
That's during the hour.